Biopharmaceuticals, a subsidiary of Emcure Pharmaceuticals, is working on India's first mRNA-based vaccine for COVID-19. Genova has received funding from Department of Biotechnology and plans to start phase 1 clinical trials in October 2020.
For COVID-19 vaccine, Genova is using next generation technology which combines mRNA and adjuvanted nanolipid carrier. This vaccine will be very low dose injectable, sustained release due to its self-amplifying mRNA platform. This will ensure safe and efficacious vaccine.
The advantage with Genova's mRNA vaccine is that it is rapidly scalable. So Genova can tap into the vast specialized nanoparticle capacity that has been already created at Emcure sterile parenteral sites to make close to 200 million doses. Additionally, our team is already partnering with different OEM manufacturers to install 1 billion doses capacity.
Led by the visionary founder, Mr. Satish Mehta, who has given many innovative and first in India products to the country. Emcure is committed in its fight against COVID and is working towards Swasth Bharat, Atmanirbhar Bharat. Jai Hind.
Good evening, everybody. I welcome you all to Foxy Medical Disorders in Pregnancy Committee, along with Genetic and Fetal Medicine Committee webinar on addressing patient needs for healthy pregnancy and know about the new generation folates. We all know that every pregnancy nowadays has become a high risk with advancing maternal age, medical disorders like hypertension, the diabetes, anemia complicating them, also multiple pregnancy, increase in the infertility treatment, and so many fetal anomalies which we all have to encounter, and we always wish for a healthy outcome for our mothers. And to know more about this high-risk pregnancy and the folic acid, we have with us eminent speakers, Dr. P.K. Shah, Dr. Sanjay Gupte, Dr. J.B. Sharma, and Silvia Pisoni from Italy. And this program is because of the Foxy, Team Foxy, led by Dr. Alpesh Gandhi, the president. I also would like to acknowledge Dr. Atul Ganatra, the vice president in charge, Dr. Jaideep, secretary general, and the chairpersons for today, Dr. Mandakini Megh, who happened to be the chairperson of ICOG, and thank you for granting ICOG points, along with my co-chairperson, Dr. Mandakini Pradhan, who heads the Genetic and Fetal Medicine Committee. So I welcome you all, and I would like to now call upon our chairperson for the session, Dr. Mandakini Megh, to start the session without any delay and introduce the first speaker, Dr. Mandakini Megh, the chairperson of ICOG. Thank you very much for being the part of this program. She's also an international vice president of Medical Women of Central Asia, vice president of AMWI, national vice of 2012-13, and who also was a Director General of Health Services for the Maharashtra government and has worked immensely in family welfare, PCP, NDT, MTP, and has so many numerous publications to her credit and is recipient of many prestigious awards. And Dr. Mandakini Megh, welcome to the webinar. And I would also like to invite your co-chairperson, Dr. Mandakini Pradhan. So we have both the Mandakinis here, and we are really fortunate to have both on the same platform. And Mandakini Pradhan, as I said, she's the chairperson of the Genetic and Fetal Medicine, but also a professor and head of department of Sanjay Gandhi Postgraduate Institute of Medical Science, Lucknow. So I welcome you all, and before I hand over the session, I would like to thank our partners today, Emcure and the TOG team, Science Integra, for this platform to bringing us all together. Thank you very much, and over to you, chairpersons.
Please stop sharing. Stop sharing. Can you hear me?
Yes, madam, I can hear you.
Yeah. So very good evening to all of you, all the dignitaries and the faculty, Dr. Sanjay Gupte, Dr. P.K. Shah, and my co-chair, Dr. Mandakini Pradhan, Dr. Pisoni, and everybody here. Thank you very much for keeping this, Komal. I congratulate you for keeping this very important webinar and CME with the help of MCure. Thank you, MCure, for being the educational partner and always there. This fetal and genetic is so important. Everybody knows about it. But from the ICOG point of view, I would like to say that ICOG is having the fetal medicine centers, which were, started when Dr. P.K. Shah must be, president that time, 3, 5, 7 years before. And now they are doing so well that itself is showing the importance of fetal and genetic medicine. And I'm also very, very pleased to inform you all that we have just started the online ICOG course of the ICOG fetal medicine from last Wednesday, and it is going on very strong under the convenership of Dr. Jayaprakash Shah, Dr. Chanmay Rotho. Also, we have started reproductive medicine, genetics, and now endoscopy also we are starting. So I think we are having a Dr. P.K. Shah today as a star speaker, Dr. Sanjay Gupte. So please display the slide of Dr. P.K. Shah. Please display the slide of Dr. P.K. Shah. Dr. P.K. Shah, I don't think anybody requires any introduction to Dr. P.K. Shah. But formally, I want to say, for me, he was my mentor. He was my president when I was a vice president. And I'm groomed by him. And I want to really mention here, when I was just a new person in this, all the organization, then he called me and he told me, Madam, can you take the post of treasurer of IFUMB? At that time, I was not very serious. I did not know what it is. I said, yes, sir, I'll take it. And from then onwards, I came into the main. So, Dr. P.K. Shah, on all the platform, I want to thank you for bringing me into the main this thing of the FOXY and the IFUMB. Dr. P.K. Shah is the professor and unit head of Department of OBGYN at GS Medical KM Hospital. He was a past dean of ICMU. He was the past president of IFUMB, past president of MOGS, past president of FOXY, and past president of IAG. Unique combination of being leading this organization very well. And he is FOXY representative to AFOC, past editor of journal, and he is basically a teacher of teachers. So I present to you Dr. P.K. Shah, who is going to talk on Komal. What is the subject? So I present to you Dr. P.K. Shah.
HRP. Yeah. HRP Indian scenario.
So Dr. P.K. Shah is going to talk on the HRT in Indian scenario. So Dr. P.K., floor is yours.
Thank you very much, madam, for your kind words. Let me share my screen. I don't know where it has gone.
I'm really fortunate to have Dr. P.K. Shah with us today. He happened to be my teacher. You said teacher of teachers. He is my teacher, and this is the most fortunate platform where I can interact with my teacher. Thank you very much.
संजय साहेबांचा बायोडेटा वाचायचा होता.
Yes, we can start seeing.
Okay.
I'm sorry, I can't get it now. Can you go for the next one, Sanjay? I hope you don't mind. Meanwhile, I
am also want to read his biodata. Please display
biodata. Yeah. Let him talk first.
No problem.
Yeah.
Session, please display the biodata.
Again, it is a really pleasure and honor to introduce Dr. Sanjay Gupte. Our professional relationship goes back up to 30 years. And when I was going to Pune as a deputy director, assistant director, and then in the FOXY, and at so many platforms, and I was just talking to Dr. Gupta that Mrs. Thakekara, who was a principal secretary health, she has appointed me, Dr. Sanjay Gupta, and Dr. Usha Saraya on the PNDT of the women's cell. And we did a wonderful job that time, and We have a great relationship with Dr. Sanjay Gupte. Dr. Sanjay Gupte at the moment is a FIGO representative, FIGO of the Ethics Committee chair. He has been awarded FRCOG by the Royal College in 2010. He was President Foxy 2010, and he's President DIPSI, Secretary General World Justice Organization. He is a chairman Technical Research Committee of ICMR, National Coordinator for the National Eclampsia Registry, which is very, very important, clinically very important. Ex-chairman of Ethics Committee, Maharashtra Medical Council. Again, very vital post for all of us doctors. Then supervisory board, ex-member PCPNDT, National Council on Medical, Legal and Ethical Issues. And he was ex-honorary professor and postgraduate teacher in OBGYN. And at present, he is a director Gupte Hospital. And let me tell you, friends, he has got a very popular teaching center of ICOG certificate courses. And he is one of the very, very highly sought after teachers and center as far as the ICOG is concerned. So, Dr. Gupte, the floor is yours. Please take it here.
Thank you, Madam Mandakini, for those very kind words, and thank you, Komal, for having me here for your committee. And it's great to have Dr. P.K. Shah and Dr. Mandakini Pradhan also in the their chairs. And of course, thank you for MCure for having this wonderful seminar. With that, let's me see, and I'll go ahead and share the screen. I think I'll be going back to that and okay, can you see the screen now or?
Not yet, sir.
Not yet.
Okay.
So may I request you to kindly press the share button and choose the PPT window that is seen at the bottom.
Where is the problem?
Dr. Shah, can you meanwhile try sharing your slides if you are able to see them, sir?
Yes, sir. Dr. Gupte's slide has come.
Yes.
I think, sir, you go to the first slide.
Yeah, I had to go to the first slide. And
Anyhow, you can start with thank you first.
yes, I already started with thank you, PK. Okay. So let's talk about genetic polymorphism, not a hidden concept anymore. Genomics and genetic itself is now something that we all need to learn, because that's going to be in not even future, is near future, that where we're all going to talk and do things, treat the patients according to genomic itself. So before we start with genetic polymorphism, let's find out what is polymorphism. When two or more clearly different phenotypes exist in the same population of a species. For example, I and Dr. P.K. Shah, with his mustache and all, so this is polymorphism, it's a dimorphism, so male, female, races, ethnicity, everything is a, polymorphism. Okay. So, even if we take the tigers, they breed differently and because of their genetic polymorphism. Okay. And so what is the definition of genetic polymorphisms? Variant forms of a gene that can occupy a specific chromosomal site or locus are called alleles. When different alleles of a given gene coexist in the species, we speak about genetic polymorphisms. Now, this is a very typical, complicated definition. So let's not worry about this particular definition right now. What we'll go do is, as we go along, we'll explain what all this means, and then it will become very simple. Try to simplify it so that the person who is not at all into genomics as it should understand. So Dr. Mandakini Pradhan, this is not for you. Please, you are an expert in this, but this is for almost lay gynecologists like myself. Okay, what are the effects of genetic polymorphism in a population? Well, they may influence characteristics like height, hair, color, everything, and some do contribute to disease susceptibility and can influence drug responses, and that's what is really important to all of us. So even if we look in the population, the simple things that we look at, our blood groups or blood groups themselves are polymorphisms, because we have different alleles of A group, B group, AB group, and so on. And they are important because they decide the susceptibility. For example, to cholera, the susceptibility is correlated with their blood group type. Those who have O blood group are the most susceptible, while those with AB are the most resistant. And in today's COVID era, we are finding out so much about genetics and genomics, and we have also found that people who have A group are more susceptible, while those who have the O group are comparatively better protected. So that's how we see these different severities in different patients across the world. This is just one of the polymorphism. So what are the genetic variations? See, we are all humans, very similar enough to be recognizable as humans, much more similar than members of many other species are to each other. For example, you look at the cats, you look at the fish, they are so dissimilar to each other, though they are in the similar species. Compared to that, we humans are much more similar, but still we have different hair, different skin, different abilities, different likes and dislikes. So we are almost unique in each of us. And remember, when it comes to our genes, we all as human beings share 99.9% of the genes. So yours and my genes are 99.9% are same. So even identical twins who originate from the same fertilized eggs are now thought not to be as genetically similar as previously thought. In fact, no two individuals are exactly the same genomically. And why? Because of genetic variation. So genetic variation is a term used to describe the differences in the DNA sequence in each of our genomes. Well, although there are many different changes to the genetic architecture which drive variation, the commonest type of genetic variation is what is called as single nucleotide polymorphism, or as a slang or colloquially, it is called as a SNP. So henceforth we are going to call it as a SNP. So a SNP is the substitution of a single base or nucleotide with another base or nucleotide. They occur throughout the genome on an average about every 300 bases, right? And many SNPs are seen frequently within the general population. As technology and our understanding of the genome improves, we are beginning to understand the importance of SNPs, although we still have a lot to learn. For instance, we know that the genetic variations contribute to the evolution of the species, and that's what actually Darwin had alluded to. And the great discovery of Darwin can explain that favorable characteristics are selected for survival and are passed on. That was the theory of Darwin, survival of the fittest. This is what we call as natural selection. In addition, we now know that some SNPs can predispose to development of disease, whereas others can protect us against the disease. So when the full set of detrimental and protective SNPs for a given disease are understood, we will be in a position to offer individual SNP profiling to more accurately determine the risk for developing a given illness. So we can have our SNP kundlis in the future. As soon as we are born, we can have our SNP kundlis and we will know what we are susceptible to and how we can maybe avoid that. We are also beginning to understand that the combination of SNPs that an individual has will determine how they respond to some medicines, such as especially important ones like warfarin, clopidogrel, and the ones which are now critically used. So let's go to the basics first. Well, this is absolutely the first MBBS knowledge that there are 23 pairs of chromosomes, 22 pairs of autosomes, 1 pair of sex chromosomes. There are 25,000 approximately genes which code for 100,000 proteins in our body. Now, more than 3 billion base pairs, adenine, thymine, cytosine, guanine are, there. And as I said, genetic code is 99.9% identical between all of us. But still, that means, 0.1% of 3 billion is still 3 million. And this explains the important phenotypic different traits we observe amongst the human species. And that's why, though we are human, though we are so similar, we are still so dissimilar. Now, what are the functions of the genes and the messenger RNAs? Because unless we understand that, we won't understand the variation. So we now know that DNA resides in the nucleus, but it replicates in the form of messenger RNA, which goes to the cytoplasm, specifically to the ribosome, and instruct to form various amino acids which form specific proteins. The functions of genes to codify is specific proteins. So, you see the first we get the transcription, that is, from DNA to RNA, and then we get the translation, which is from messenger RNA to the proteins. Now, the changes in the gene sequence lead to changes in the proteins formed, and that's where all that matters, because the proteins are the ones which make difference in our body. So again, let's understand a little more about alleles. An allele represents one of the 2 or more versions of a genetic sequence at a particular location in the genome. And this allele business actually was brilliantly discovered by none other than Mendel. We know a long back, about 200 years back, and when through the peas he found different traits in the peas and decided these alleles. The term genotype refers to the 2 alleles inherited for a particular gene, right? So we come back to the single nucleotide polymorphism. So you take a sequence, say it is TAGC, and then change that G to C, then that becomes TACC, and such different single nucleotide polymorphisms. You know how many there are in the human genome? There are 150 million SNPs in that means polymorphisms in every one of us. So when a nucleotide change is very rare and not present in many individuals, it is called as a mutation. When this a single nucleotide changes, but if it one of the rare ones, then it is called as a mutation. But in contrast to mutation, genetic polymorphisms are usually considered normal variants in population, because when a specific allele occurs in at least 1% of the population, it is said to be genetic polymorphism. So, like, I'll give you an example. For example, we know the skin color. A skin color, there can be blacks, there can be white. This is the polymorphism. Changes because we find more than 1% of the people will have this, different polymorphism. But take it as albinism, which is also kind of a skin color, but it is very rare, and that's why we call it as a mutation. So that's why this is the difference. So what happens is, mutation is any change in a DNA sequence away from normal, that is allele frequency is less than 1%. Polymorphism is where allele frequency is more than 1%. So depending on the population, a mutation can be a polymorphism, and another population, depending on prevalence, it can be a mutation. So this is something very interesting, and think about it a little bit, discuss if time permits later on about it. Okay. So the DNA contains the genetic code in the form of nucleotide bases that we have said. The genetic code is read in groups of 3 nucleotides. So 3 nucleotides form a word, or it is also called as a codon in language of genetics. So if there is an allelic variant, suppose you change one sort of a allele or this thing from the word, then there is a change of that word, and that change of the word can be still synonymous, and if it remains synonymous, so if the codon can be changed, but still it may code for same amino acid, as we can understand. While, sometimes if you change the letter of the word, that the whole meaning of the word will change, and that means if you alter a particular triplet codon, it will alter the amino acid composition that it creates entirely and will create trouble for you, right? So the most common form of polymorphism we are saying is single SNP that we have seen. Now, single nucleotide polymorphisms can affect the gene function, as I just told you. So what are the different type of substitutions that we get? And here the genetic nomenclature is very peculiar. Well, one simplest is the synonymous. That means the substitution causes no amino acid change in the protein that it produces. Just now I told you, you may have changed the letter, you may have changed the nucleotide, but still that nucleotide is producing a similar amino acid or the same amino acid. So, the whole thing will not change. But there can be another one, and that is called as non-synonymous. And this used to be also, part of it was called as missense polymorphism. What does it mean is that if you change alter one letter or one nucleotide, then the whole protein changes, and that's why the whole effect changes. But there can be another one also, which is peculiarly called as a nonsense, change or polymorphism, and that is when you change one word, that particular codons or particular words are the last words of that particular, and then the whole transcription stops and the whole protein is kind of curtailed, and there are changes can occur in various ways. So SNPs may also occur in regulatory regions of the genes, which you need not go into the details of it, but these SNPs are capable of changing the amount or timing of protein production also. Now, there are other kind of polymorphisms, what are called as repeat nucleotide polymorphisms, where the repeated these codons are changed. So the sequence are repeated, of which there can be 2 nucleotides which come repeatedly, or 3 nucleotides can come. So they are called as dinucleotide and trinucleotide repeats. Then there can be insertions and deletion polymorphisms. That means insertions and deletions can be as small as 1 base, which we will call as SNP, but they can be many bases or sometimes full exons or whole genes also. So polymorphism and genetic predisposition. This is very important. Polymorphism has a role in predispositions of diseases. Sometimes the healthy gene is replaced or edited by other gene which remains in the genome, and later on when H factor triggers, it causes the disease. And this we have seen many times. Some diseases, though they are contracted in early age, they manifest in later age. For example, the herpes zoster you have seen. Then even some forms of tuberculosis that we see. We always used to say, oh, immunology changes, we become weak, and then we get the manifestations. No, there are changes, sometimes at this genetic level also. So because of the combined effect of 2 or 3 alleles in different from single allele, the most important factors in diseases. So what can cause these, polymorphism? Age can affect it, environment can affect it, nutrition can affect it. So to understand the correlation between the polymorphism and predisposition, so let's look at some metabolism related gene polymorphism. And I think next 2 lectures are going to be about MTHFR receptor gene polymorphism and how that polymorphism affects absorption of folic acid and how it affects the whole Krebs cycle effect, and then it affects causes so many issues including anomalies in our body. Similarly, vitamin D receptor gene polymorphism can keep us from absorbing and utilizing the vitamin D that we have. Interleukin gene polymorphism again has proved to be extremely important in today's COVID world. We have learned so much about some people suddenly developing the inflammatory storm and all that. That is because they have, interleukin gene polymorphism. So that is, so COVID is really, teaching us a lot about this genetics and genomics than before, and that's only thankful thing about I think this particular issue. Now let's look at something called as genome-wide association studies. So we have discussed a vast amount of variation contained within the human genome. There are two different ways which this variation can be identified. The use of array CGS, or also called as a microarray, which are kind of a microchips, which help us, in identifying the copy number variant, so-called, or the dosage variants. That means they give us idea about what kind of genes are there in that particular this thing compared to the normal genome. Then next generation sequences is of course the latest and the best available thing to us, that where we can read all the 300 bases of DNA and try to make headway into it. There is another method though, and that is again important for identifying the DNA variations, and this is called as SNP genotyping, or also called a genome-wide association studies, or GWAS. And what is important about it, I'll give you an example. GWAS are used to identify whether common SNPs in the population are associated with disease. For example, we take people maybe who have diabetes, and then we take people who have, who are not diabetic, and then we try and study their, SNPs. And as shown here, look at the position 5. If the position 5 SNP is changed, in various people, and then we collect these people, study all their genome, and collect them together. Okay, these are the people who are having this SNP change or polymorphism in their position 5. Then if we group them together, then let's see what happens. The purple circles represent the G nucleotide, and the white circle represent the C nucleotide. So here we can see the people with a condition, that is diabetes, are more likely to have the G nucleotide than the people without the condition, that is control, so who are more likely to have the C nucleotide. So a test can be done to see if this difference is statistically significant, and if it is, then the G nucleotide is said to be associated with that specific disease. So eventually now we'll be able to even predict, by our genomics and polymorphism, what we are going to get and when we are going to get, and whether we are in diagnosis also. This is going to be vitally important even before other signs come, and this is true of everything. It is true of cardiac disease, it is true of, you name it, and everywhere this is going to be the future. So GWAS looks at hundreds of thousands of SNPs across the whole genome to see which of them are associated with a specific disease, whilst many thousands of SNPs have been found to be associated with many different diseases. The actual level of increased risk caused by individual SNPs is almost always low, usually between 1.1 to 1.4 times. And this is the problem, and that's why we still need to learn and research a lot more to actually come to the diagnostic. So the people from different ethnicities also have different numbers of SNPs in their genomes. Some SNPs are only present in one ethnic group and not present in many others. And we know Ashkenazi Jews have so many of these polymorphisms and genetic variations that they are prone to many conditions which other people are not. So let's come to some practical points now. Okay, so first, what is the practical application of all these polymorphisms? So one is the pharmacogenomics. So we know that there are variable responses to the drugs, and that's why there are adverse drug reactions. In Canada, every year 2,000 deaths, and this is a statistics they have, we don't have our statistics, just because of adverse drugs reaction, and 7.5% of all hospitalizations are because of adverse drug reactions. So heritability of drug response can be established for selected drugs like dacumarel, clopidogrel, and so many others. If we are able to do that, we'll be able to avoid these adverse drug reactions. And this is very simple. Suppose tomorrow, when you say in advertises like this, that there's wonderful suits and all, one size fits all and all this. You will ridicule them. "Okay, what is this going on?" But in practice, that is exactly what we are doing. We are using the same drug, same dosage for everyone, forgetting that everybody is different. And we are saying, "Oh, we are doing standardization," and what a great standardization. So this is where we land in trouble. And then we try and create evidence on that basis, and then say, "Oh, this is evidence-based medicine." So this is where we land in trouble. So there is a huge potential of pharmacogenomics. From the population and polymorphism, we can find who are non-responders and toxic responders. Then treat them with alternative dose agents, and the proper responders we can treat with conventional drugs. So pharmacogenetic is very important. Genetic information may be used to predict whether a person will respond to a particular drug, how well they will respond to that drug, and whether they are likely to get any side effects from the use of a specific drug. This allows their treating team to make individualized decisions about the right drug treatment. So finally, what are then the clinical applications of genomic technologies? So the clinical applications are so many. The gene discovery and diagnosis of rare monogenic disorders. Friends, when it started in 1990, there were just 50 disorders which could be made out from single gene disorders by identifying them. Now there are more than 6,000 diseases. So the things are so rapidly progressing. Then identification and diagnosis of genetic factors contributing to common disease. Genomic technologies are increasingly being used to understand the contribution of both rare and common genetic factors to the development of common diseases such as high blood pressure, diabetes, and especially cancer. Then targeted therapies. We talk about pharmacogenomics, but this is a little different form of it. In some cases, such as cancer, we can identify the genetic drivers or driver mutations, as they are called, of the disease, and then give drugs which specifically target that particular pathway. And this is known as targeted therapy, which is now so vital in cancer treatment that you can avoid so many of the side effects of the so-called old chemotherapy that we used to do and still do in many cases. The prenatal diagnosis and testing, I need not tell all our friends here about importance of PGD, importance of NIPS, and now there is wide NIPS, not just for Down syndrome and 18 and 13 aneuploidies, but now it can be extended to many more diagnoses also. The use of NGS and array technology in prenatal samples is also on the increase to improve diagnostic yields in a pregnancy. Infectious diseases. Now again, COVID had taught us so much that all the microorganisms need to be identified with their genetics. Then we have to find out what drugs or what vaccine which we can create. But for that we need to know their genome. We need to know their variations. We have to act on those. And finally, the personalized medicine, as the exact DNA sequence of the genome of each human is unique to them, we will all have the unique disease susceptibilities and treatment responses. Personalized medicine describes the use of our genetic information to tailor healthcare intervention to our own individual need. Gene therapy. Gene therapy involves administration of DNA or RNA in order to correct a genetic abnormality or modify the expression of the genes. And the most cutting edge of them all, which has received the Nobel Prize this year, is the genome editing. CRISPR-Cas technology uses molecular techniques to modify the genome, and genome editing can add in, cut out, or replace sections of the DNA sequence, and that is going to be the whole revolution in a near future. So friends, in what we are going to have in near future is the genomics and the gene technology, and that we now have is going to make a difference in every field of medicine. We'll be talking about personalized diagnosis, we will be talking about personalized therapy, and there will be no generalization in near future, and we'll be very specific and very correct. And that's why it's time that we start learning this science soon for our own survival. Thank you so much for your kind listening.
Thank you, sir. That was a great talk on genetics, which is little difficult, and that too polymorphism. It's a difficult chapter, but made very simplified by you. If Dr. Saha is ready with his, can I ask Dr.
Ready,
P.K.
ready.
Saha to?
Yes, I am ready.
Yes, sir. You
After,
can
after
continue
Dr.
with it.
Sanjay Gupte sir has now told us about entire geography and the structure of all the genes and everything, and so beautifully explained by you, sir. And now Dr. P.K. Shah is going to talk about its application, how the high risk pregnancy, and what is the Indian scenario, which is the must needed. We should know what are we going to deal with. So over to Dr. P.K. Shah, sir. We can see your slides now
Yeah.
very beautifully. Yes.
Sanjay, I enjoyed your talk thoroughly.
Thank
And I
you.
learned a lot, to be honest.
Thank
If
you.
someone asked me to read this topic, I would not have. I would not have read this topic, but because we are in webinar together, I enjoyed it thoroughly.
Thank you.
Congratulations.
Thank
Very
you.
good topic.
I'm looking forward to your talk.
Yes. Now, high risk pregnancy, one can write books. And when I was asked to give about Indian scenario, I didn't know what to really include, because we have so many books on high risk pregnancy which discusses each and every abnormality of pregnancy in thorough details. But because it was Indian scenario, I thought it would be more of a statistics. So I am happy to present to you some of the statistics as far as high risk pregnancy is concerned. First of all, let me thank Dr. Komal Chavan, Chairperson of Medical Disorders Committee of FOXI, Dr. Mandakini Pradhan, Chairperson of Genetic and Fetal Medicine Committee, for giving me this opportunity to deliver this talk on high-risk pregnancy Indian scenario. And thank you, FOXI office bearers, for having us here. And my dear Mandakini Meg and Mandakini Pradhan, very rare combination. I have never in last 8 months seen these two Mandakinis together. So it's a twinning has occurred in chairperson's post. Now coming to definition of high risk pregnancy, to make it very short, it is one which is complicated by factors that adversely affect the pregnancy outcome, whether it is maternal or perinatal or both. 15% of all pregnant women can develop potentially life-threatening complications. Adverse obstetric and neonatal outcome common in women with high-risk pregnancy. So diagnosis of high-risk pregnancy at early stage can help in achieving favorable maternal and neonatal outcome. So what is the scenario as far as high-risk pregnancy is concerned in our country? That 20 to 30% of pregnancies are in high-risk category. And HRP is responsible for 75%, 3/4 of the perinatal mortality and morbidity. And almost 1/5 of pregnant women in rural areas have high-risk pregnancy. And we have to tackle all these high-risk pregnancies even from smaller places. Who all are at high-risk pregnancy? And it's a very big list. I cannot include all, but I have picked up some of the important factors that lead to high-risk pregnancy. These are the conditions that predispose an antenatal woman to a high risk. And that includes severe anemia, hemoglobin less than 7 grams per deciliter, hypertensive disorders in pregnancy, pregnant women with HIV positive or HIV or syphilis positive, or any venereal disease for that matter, hypothyroidism. We all know what are the normal levels of TSH in different trimesters. Gestational diabetes, glucose challenge test showing you more than 140 milligram per deciliter. Multiple pregnancy, previous history of C-section, young primey less than 20 years or elderly primey more than 35 years, all malpresentations, bad obstetric history, RH incompatibility, and placenta previa. If you see, there are almost 40 more conditions one can talk about, but these are the commonest. As far as we are concerned, we get only many of these that I have listed in our practice. So, what is the frequency of various predisposing factors in human as far as HRP is concerned? And we have a hypertension coming in almost 53% of patients, younger, primary or elder, 33%, hypothyroidism 12.5%, malpresentations 11%, severe anemia 6.3%, RH incompatibility again 6.3%, twin or multiple pregnancy again 6.3%, and then the gestational diabetes, pregnant women with HIV, etc., coming in lesser percentage. In a study that reported a 30.7% prevalence of high-risk pregnancy in our country, almost 60% of these women had a bad obstetric history. So it is very important that you take a proper history, especially obstetric history, when a woman comes to you. 4% of these women had pregnancy-induced hypertension. 5.5% of these women were elderly gravida. 3.2% were RH negative, and 22.3% had other risk factors. Now, there are certain factors we don't take into consideration. Factors like education status of pregnant woman, age at pregnancy, and parity of pregnant women were found to be significantly associated with prevalence of high risk. Prevalence of high risk pregnancy was higher, that is almost 77% in multigravida compared to primigravida. And this is how we have the factors and the percentage. This is a very good paper which was published in June 2020 in International Archives of Integrated Medicine. That you had, as far as socioeconomic status, below poverty line almost 84%, 60% multiparous patient, or rather multi. Parity, nulliparous 42 and multiparous 57%. Unbooked 42%. Look at this. Now all these will have some or the other problem during pregnancy and labor. Prenatal diagnosis involves initial screening to a high-risk couple followed by definite diagnosis. And there are various screening methods, as we all know. That history is very important. One must take a thorough history during past and present pregnancy, like taking teratogens, contact with patients with infectious disease, history of some disease, anemia, and various factors that one can go into details of. In family history, minimum 3 generations, you must take proper history and history of consanguinity. And when it comes to examination, as in any clinical setting, detailed examination is very important in a pregnant woman with high-risk pregnancy. Then examination of the couple, when do you want the male partner to come? Single incisor teeth in holoprosencephaly, features of myotonia and recurrent polyhydramnios, spinal abnormality in spondylocostal dysplasia, all this picked up on ultrasound. Then there are investigations that one should order and various screening and diagnostic procedures for prenatal diagnosis. Actually, we can't go into the details, but this slide, I will read it out for you. And you can have a maternal serum screening. Either in first trimester screening, you have a triple test or quadruple test. Integrated screening can be done, or sequential screening and contingent screening. Then you have a most important thing, that is a fetal imaging, where you have a 2D, 3D, 4D ultrasound, Doppler ultrasound, and if required, MRI. You can do invasive diagnostic procedures for various screening and diagnostic modalities that are available to us, like amniocentesis, chorioangular sampling, fetal blood sampling, fetal tissue biopsy, fetoscopy, etc. And you can ask for pre-implantation diagnosis in some of the cases. When it comes to prenatal diagnosis, the first trimester screening includes nuchal translucency. We all know very well about it. Nasal bone, Doppler study of ductus venosus, pregnancy-associated plasma protein PAP-A, and free subunit of beta HCG in maternal serum. When it comes to second trimester screening, the indications are pregnant women who present for the first time in second trimester, or when expertise in first trimester screening is not available, then you will have to do second trimester screening. You can do a biochemical serum markers or sonographic detection of major structural malformations, sonographic evaluation of minor markers to pick up the chromosomal abnormalities. Then biochemical markers, maternal serum alpha fetoprotein and beta HCG, free unit, unconjugated histiol, and inhibin A. In all this you can do, and we are not going into details of this genetic screening in second trimester, and you can have a combined first and second trimester screening or integrated screening, etc., or you can have a sequential screening as a and when required, depending on the type of patient that you get. Fetal imaging includes sonographic detection of major fetal structural malformations like that of cardiac, gastrointestinal malformation, nervous system, skeletal malformations, renal malformations, and facial anomalies. And you can use other imaging modalities like 3D ultrasound and MRI. Observational studies and interventional project, International Society of Prenatal Diagnosis Committee recommends ultrasound nuchal translucency at 11 to 13 weeks gestation and serum markers between 10 to 13 weeks, extending option 1 to include other first trimester sonographic markers if needed, as we discussed. A contingent test whereby women with both risk from option 1 have option 2 and risk is subsequently modified. And you can have a quadruple test between 15th to 19th week of gestation of women who present after 13th week, 6 days. You have a combining option of 1 and 4 in either a contingent protocol, provide that all screening data is included in the final risk assessment, and contingent second trimester ultrasound for aneuploidy for women having option 1. Ultrasound performance must be prospectively done and validated. Cell-free DNA screening for women classified as high risk by any of the above options 1, 2, 3, 4, 5, 6. Now, once you've done the diagnosis, what you have to find out as far as our country is concerned is what is the obstetric outcome. And we are going to see what is the type of delivery, whether it was term, preterm or post-term, and what are the mode of delivery, spontaneous vaginal delivery, assisted vaginal delivery, or C-section. And neonatal outcome will include birth weight of child, whether it was low birth weight less than 2.5 kg, or normal baby with birth weight more than 2.5 kg, and what was the status at birth, whether it was a live birth or stillbirth or abortion. Now here is again latest thing that has come in June 2020 in International Archives, that out of 1,176, preterm delivery occurred in almost 79%, term in 19%, and post-term in 2%. The mode of delivery, 51% had vaginal delivery, 7% have elective C-section, and 42% had emergency C-section. 31% of the babies had low birth weight and 69% had normal birth weight. 94.6% of these high-risk pregnancies, 1,100 plus, had live births, whereas 5.4% had stillbirth. Now, when they compared this with a normal pregnancy, what was the difference? That in normal pregnancy, 11% had preterm, whereas in high risk, 19.4. Term 37 to 42 weeks, 84% in normal, 70% in HRP, and post-term 4.6% in normal pregnancies and 10% in high-risk pregnancy. Spontaneous vaginal delivery occurred in 75% in normal pregnancies, where it was 67%. LSCS 23 in normal patients, 30.9 in HRP. Birth weight was low in almost significantly higher, more than double in high-risk pregnancy. Live births were fairly same, but stillbirth was slightly more, and it was 4.7 and 6.7. To summarize my talk, ladies and gentlemen, complications and threat to the health of mother and fetus are increased during pregnancy, as we all know, especially if there are any medical disorders. Many risk factors in pregnancy are preventable, like anemia. Early diagnosis is very important, and the role of each medical professional and antenatal care is crucial in managing such patients. So, early detection and effective management of high risk pregnancy can contribute substantially in reduction of maternal and fetal adverse outcomes. Ladies and gentlemen, the statistics is very worrying, and the problem comes because many of these patients do not deliver in the hospital, and that is the biggest issue which we have to tackle, whether we do it through our ASHA workers at a grassroots level. We will have to see that the antenatal care reaches all these women in even smallest possible place in our country. Thank you very much for your patient hearing.
Thank you, sir, for that excellent talk on high-risk pregnancy. It's truly a voluminous book. I was thinking, how do you approach it? But that was in a nice quote of the recent literature, and probably we need to work on it. There are few guidelines that how do you calculate which pregnancy is high risk or not, and specifically in COVID era, which patients are to be called for a physical visit and which are to be on teleconsultation. So lot of work is going on and needs to be done by all of us.
Yes,
so, but then that was very nice of you, and then doing justice to this wide topic. Then I'm delighted to introduce the next speaker.
Yeah, before just Dr. Anjali, just before
Yes.
there is a question for Dr. PK Shah sir.
Okay.
And when we have both the stalwarts with us, Dr. PK Shah and Dr. Sanjay Gupte, and we have almost 2,000 users logged in right now, and so many questions and a lot of appreciation messages are coming. And there is a question to Dr. PK Shah from PA Ramani, Vishakhapatnam. Sir, please explain the prediction of preeclampsia. I know it's a very vast topic, but sir definitely is an expert in ultrasound, and definitely you can sum it up and give few words about it, Dr. PK Shah sir.
Okay. Now, when it comes to prediction of preeclampsia, we have a very simple non-invasive way we can do it, and we have brought down the screening from 18 to 22 weeks to almost 11 weeks to 13.6 weeks, and that is in the form of uterine artery Doppler. What is important is that none of us does uterine artery Doppler in first trimester. Honestly, I'm telling you, you keep talking to people the same thing again and again, but when it comes to practice, very few people really accept this as a method to really predict preeclampsia. So what is important is that we do uterine artery Doppler and find out PI on both the sides. And we have a PI of one uterine artery right, one on the left, and add and divide by 2. So we have a mean uterine artery PI. If it falls within 5th to 95th percentile, we know it is normal. If it goes beyond 95th percentile, that means the uterine PI is high. You know there is an increased resistance to the flow of the blood in uterine artery. So what is the meaning of that? That tells you that there is some resistance to the flow of the blood in uterine artery. Now that leads to less and less blood going to the placenta because of constriction of the uterine artery or any vessel for that matter. And that gives you the prediction. But what is important is that even if you have 100 patients studied with this in 11 to 13.6, you will be right in almost 56% of patients. And there is a very high false positive, unfortunately. So we will have to do screening again between 18 to 22 weeks, more nearer 22 weeks to find out what is the situation at that point of time. But if you have a patient who is at high risk of getting preeclampsia in present pregnancy because of previous obstetric history, you can start low dose aspirin 150 milligram in this patient daily from even first trimester itself. That is the advantage. Okay.
Thank you so much, sir. It was so wonderfully explained with you. And there is also one question from Dr. Saunindra Goswami, Kolkata. Severe congenital anomalies detected very late, more than 20 weeks. What should I do? Advise the mode of delivery. So it's a debatable thing, but I think Dr. Pikesha sir or Dr. Sanjay Gupte can guide us when we detect a late detecting congenital anomaly. What option do we have? How do we deliver and terminate?
It's very simple. That if you have a congenital anomaly which is not compatible, hello?
Yes, sir. Yes, sir.
Can you hear me?
Yes, sir.
Okay, which is not compatible with life. And if she comes after 20 weeks, why? Because in our country, we can do medical termination of pregnancy up to 20 weeks officially. Though it has been accepted, it has not been passed in Vidhan Sabha and it has not become a law as yet. But you can do it up to 24 weeks once the law is passed in both the sadhans. But once you have found out a congenital anomaly like say anencephaly, after 20 weeks, you have no option. You cannot deliver this patient or abort this patient officially with things written down on paper. You have to counsel the patient and her relative, especially the husband, about high mortality or almost 100% mortality of depending on the case that you have. You must explain in detail to this and you have to tell very clearly that in India, with the laws, MTP laws that are available, we cannot terminate this pregnancy officially. Unofficially, what you can do, what somebody else does, this is not the platform for me to say anything. Okay, patient can go in preterm labor anytime and she can deliver. But this is not the platform for me to tell someone what to do after she comes after 20 weeks and she has a lethal congenital anomaly.
Thank you very much, sir. I think Dr. Mandatni, we can proceed. And it was really pleasure to listen to both Dr. P.K. Shah and Dr. Sanjay Gupte, sir. Over to you, Dr. Mandatni.
Yes. Again, can I have Dr. J.B. Sharma's slide, please? Yes. I've got the pleasure and honor to introduce Dr. J.B. Sharma. He is professor at All India Institute of Medical Sciences, New Delhi, and he is FRCOG. As we know that he has written many books, and one of the gynecologists who has published maximum number of articles and journal, and probably many books in both obstetrics and gynecology. He is now the chairperson of it's not written in his this thing. See, he is so simple that the written material that he has submitted is missing out his chairpersonship of the committee in FOXI. He is widely known to write on genetic tuberculosis, anemia, pregnancy, then urogynecology. the committee which he is chairing. So I have got the privilege to call upon him to discuss on different folate choices and their comparison, the conventional one versus the new ones. We are all eager to hear you, sir. For everyone's information, there are 2,154 people logged in at present. Thank you. And over to you, sir.
Oh, great. Thank you very much, Dr. Mandakini and Dr. Komal, for a nice introduction and for inviting me. I'm really delighted to have so many audience and all. And Dr. Mandakini is doing such a wonderful job, and Dr. Komal Chauhan. And the lectures I attended part of the lectures by Dr. Sanjay Gupta and Dr. P.K. Sir, they were really out of brilliant lectures. So we start, thank you very much for this thing. And Dr. Komal is well known to organize such brilliant conferences as Dr. Mandakini. So we'll have the various different folate choices. I mean, it may look a very simple topic, but I mean, what I really want to highlight here is that, even now we see patients, even medical, like gynecologists, and who had not taken periconceptional folic acid. So this is really a shame that somewhere we are lacking in our knowledge, somewhere we are lacking in our training, that even empty gynae girls are not taking periconceptional folic acid. So it's real shame. So I think we have to highlight all our MBBS students and all that, periconceptional folic acid is a mandatory thing. They have to take it. And as far as the dose is concerned, they can take 400 or 500 microgram, which is usually available in India as 500 microgram. So all low risk women need to take 500 microgram of folic acid, which is present in most of the multivitamin tablets, has to be taken during periconceptional period to prevent not only neural tube defects, but there have been now enough studies that they prevent cardiac defects and other defects also. So it's a really public health measure. In the USA, UK and other countries, the wheat flour available in the market is fortified with the folic acid, and folic acid is very safe for the men also. So that has to be taken. And now, I mean, various for simple low risk patients, any folate, folate can be taken 400 to 500 microgram, even multivitamin tablet can be taken. But if it's a high risk patient like diabetic, pregnancy and all, then the dose has to be increased to 1 milligram, or preferably if the past history of neural tube defect and all, then it has to be 4 to 5 milligram by ACOG, but we in India give 5 milligram. So if any doubt, family history of neural tube defect in the sister or in the patient in the past and all, then the dose is 5 milligram folic acid. But now the problem is that the folic acid which we give, the newer concept has coming up, which will be in my talk and the talk after me also, that the folic acid we are giving, is it that folic acid will provide the active folate in the body, or it will not pass the enzyme, that we'll be discussing. So different folate choices you should know. When we are prescribing, we should prescribe the right folate which will bypass that enzyme, and that active folate is given to the patient to prevent neural tube defect and the megaloblastic anemia and other. Next, please. Can we have the next slide? Yeah. So the nutrition requirement in pregnancy, as we know by this slide, is a bit congested slide. I mean, we require, and the highlighted one is the folic acid. So folic acid, I have highlighted you, is that 400 to 500 microgram is the dose for the low risk patient, and for high risk patient, depending upon this, it can be 1 milligram to 5 milligram. Next, please. Okay, so folate is available, and we know that it is a B9 vitamin. So function is, it's a carbon donor in the synthesis of amino acid, purines, pyrimidine, and bases required for DNA synthesis. So it's required for DNA as well as RNA, but mainly for DNA, and a methyl donor in the production of methylcobalamin and methionine. So both folic acid and B12 are required for DNA synthesis, and folate is a provider. So women with folate deficiency are also more likely to present with congenital anomaly affecting pregnancy. We all know that periconceptional folic acid has been associated with decrease in the amount of neural tube defects, not only neural tube defects, cardiac defects and other defects also. So it's a really important message. There's such a simple vitamin, cheaply available at throwaway rates, can prevent neural tube defects almost 80 to 90% cases, cardiac defects and others also significantly, not to that extent, but also significantly. Next, please. Okay, so we know that how the RDA, that means 500 microgram is the dose required for pregnant women, and the nutrition requirement, and for India as by ICMR and NIS standard. So we all know that how important it is, and the high prevalence of folate deficiency is there in India. There was a study from Safdarjung Hospital and in AIM that both folate deficiency is very, very common. I mean, it's second only to iron deficiency anemia. But mind it, we should not forget B12 also. B12 deficiency can also be seen. So both folate and B12 deficiency are there, but folate is definitely much more common. And we all know that it can cause megaloblastic anemia. We all know that folate deficiency can cause neural tube defects, can cause cardiac defects and other defects. Next, please. So 500 microgram is the minimum RDA. That is the minimum requirement. But for high risk cases, that patient on anticonvulsant drugs, patient on antitubercular drug, patient on other medications, and patient with diabetes or patient with a family history, they require higher dose. So there the dose may vary from 1 milligram to 5 milligram. If in doubt, it's better to give full pharmacological dose, which is 5 milligram, and the right type of folate. Next, please. So folate supplements used are basically, we use either folic acid tablet. You can use as tetrahydrofolate 5, tetrahydrofolate, and these other brands available. Okay. So but we have to know that out of that, so much plethora of folates are available, which folate we should use. And of course, dietary folate also, we must not forget that we need to recommend to the patient to take the medication, the sort of diets which are rich in folates, including green leafy vegetables, non-veg preparations and all. So we need to highlight that also to the patient. But do we need to give simple folic acid? Do we need to give one of these folate, or we need to give the tablet which bypasses the enzyme, which we'll be discussing in the next slide. Next, please. Okay, so we all know that supplementation of folate may occur on folic acid, folinic acid, or 5-methyl tetrahydrofolate. So naturally occurring 5-methyl tetrahydrofolate has important advantages over synthetic folic acid. So it is absorbed even when gastrointestinal pH is altered, and bioavailability is not affected by metabolic defects. So if you use the traditional folic acid, which is available and in the government hospital and all, so it will not actually be absorbed properly. It has to be dependent on the pH. pH has to be, what is required for this absorption of this thing. While the 5-methyl tetrahydrofolate does not require any defined pH, so it can be absorbed at any pH, and it will not be required for that enzyme deficiency, which we'll be discussing. Next slide, please. Okay, so different metabolic handling of reduced folate and folic acid in the human body. We know that folinic acid failed to increase circulating folate levels proportional to the dosage. So when the review studies were there, so 2 or more different forms of folate are shown to no different significant differences between the groups except for methyl tetrahydrofolate, which was the most bioavailable. So what I want to highlight, that methyl tetrahydrofolate, that means 5-MTHP, is the best folate available because it does not require any defined pH. It can be absorbed even if the pH is different, and it can be absorbed in the presence of other fats and other foods. And it is like, when it is absorbed, it gives the best bioavailability. Next, please. Okay, so I want you to see this slide a bit more carefully. So normally when we are giving normal traditional folic acid, and then it is ultimately converted into 5-10-methyl tetrahydrofolate, and then we have this enzyme 5-10-methyl tetrahydrofolate reductase. This I want to highlight with the red mark is there. So that enzyme is the most crucial enzyme, and that converts it into 5-methyl tetrahydrofolate. And it is the 5-methyl tetrahydrofolate which is the actual donor of carbon atom, and this is the actual folate, active folate in the body. So what I want to highlight, that the folic acid has to be converted to 5-methyl tetrahydrofolate to be active. So this is the important concept for our esteemed viewers, that this folic acid is first converted into 5-10-methyl tetrahydrofolate, and that 5-10-methyl tetrahydrofolate has to be converted to 5-methyl tetrahydrofolate by the enzyme 5-10-methyl tetrahydrofolate reductase. So this enzyme, that means 5-10-methyl tetrahydrofolate reductase enzyme, is deficient in many women. We don't know the exact data of India because the studies have not been done, but we expect that at least about 20 to 30% patients may have the deficiency of this enzyme. But the problem is that ideally you should be knowing that your patient has got deficiency of this enzyme, but problem is that this deficiency of this enzyme is not easily detectable by the lab test, and it's extremely expensive. While the folic acid tablets are so economical, so cheap. So instead of, either you do like routine testing on all women about this enzyme. If they are deficient, then, you give them this 5-methyl tetrahydrofolate for preparation. And if they are not deficient, then you can give them any folic acid deficiency. But doing that will cost many thousand rupees and not available everywhere. So then what is the solution then? So why not then? Why to take risk? I mean, if your traditional folic acid is effective in only 50 to 60% or maximum 70% patient, what about those 30 to 40% patients who are deficient in the enzyme? Deficiency can be very severe, can be mild to moderate also. But in all those patients, if you give 5-methyl tetrahydrofolate, you will bypass this enzyme. So then, doesn't it make sense, that common sense, that if you give 5-methyl tetrahydrofolate form of folic acid, then it is not dependent on that enzyme and it will work in all 100% patients. So we are sure that when we are giving 5-methyl tetrahydrofolate, we are bypassing that enzyme. So whether the patient is deficient in the enzyme or not doesn't matter, because it will still work. So that is the important concept I want to highlight. So it makes sense, economic sense also, and the cost, traditional folic acid plus 5-methyl tetrahydrofolate, the difference in cost is not that great. It's not that it's 100 times more costly. It's just maybe 1.5 to 2 times more costly, and so it makes actually economic sense to give 5-methyl tetrahydrofolate, and it makes biological sense. It makes scientific sense actually. So that's what I want to highlight, that even without doing enzyme deficiency testing, we can straightway give 5-methyl tetrahydrofolate. Even if the patient is not deficient in enzyme, it will not do any harm. It will still be useful. It will be very effective. So that's next, please. Yeah. So the same thing basically highlighted in this slide also, that if you see the folic acid converted into dihydrofolate, then tetrahydrofolate, then 5,10-methylene tetrahydrofolate, and then this enzyme 5,10-methylene tetrahydrofolate reductase will convert into L5-methyl tetrahydrofolate, which is the active form, and this will ultimately work. So we, by bypassing this enzyme, if we give L-methyl tetrahydrofolate directly, so we bypass the enzyme and it will work in all the patients. And we know that intestinal folate absorption from the breast border membrane through the mucosal cell via the portal vein into the peripheral circulation. So this is what I want to highlight, that we can bypass this enzyme and it will still work. Next, please. Okay, so in summary, I haven't written anything here. So what I really want to highlight, that number one, I want to highlight that please do prescribe periconceptional folic acid to all your friends, to all your patients. I mean, it's just shame that even now patients in All India Institute of Medical Sciences are coming. Our gynae residents are coming who have not taken periconceptional folate, and by that time they come to me, they are already 6 to 7 weeks pregnant. And Dr. Mandakini will agree with me that the neural tube is already formed, and such a simple thing, such a cheap thing. I mean, I got that something 1,000 rupees cost, just 1-2 rupee tablet, and the patient to prescribe. I want to highlight, then when like diabetic, the patient is high risk, then we have to give 1 to 5 milligram depending on the condition. Otherwise 500 microgram is good enough. And when you are prescribing the prescription, why not to prescribe that medicine which bypasses that enzyme? So you give 5-methyl tetrahydrofolate preparation are available in the market now. So it makes sense to give that prescription to the patient, and then you can really prevent neural tube defect in the fetus. You can significant, almost 90% prevention. You can prevent cardiac defect and other defects significantly, not to that extent, but significantly. You can prevent megaloblastic anemia in the patient, and others. So it makes sense to prescribe folic acid to all these patients, and the right type of folic acid. Thank you very much.
Thank you, Dr. JB, sir. Thank you, Dr. JB, for that excellent talk. If I am allowed to summarize all three of them, previous neural tube defect, Dr. Sa nicely pointed out, is a high-risk pregnancy. Now we have got MTHFR or methylene tetrahydrofolate reductase. In India, if we analyze our own data, then around more than 70% of women who have got previous history of neural tube defect are presenting in the subsequent pregnancy without taking folic acid. I fully agree with you, sir. Next, MTHFR polymorphism in India, the data is not there, but then anecdotal data says that it is still prevalent, and we can look for that polymorphism in that gene, as nicely pointed by Dr. Sanjay Gupta sir. Next, coming on to, we have got folic acid, methylene tetrahydrofolate. So we have got a choice to choose, and Dr. JB Sharma nicely told what to choose. And so I open this talk for any questions. Dr. Kamal, can you take up, Dr. Komal?
Yes, Dr. Badni.
Yeah.
It was really a great talk by Dr. J.B. Sharma, very nicely explained different types of fluids. And there are so many messages and questions, and because there are so many users who have been logged in, and many have congratulated all the speakers. Sir, if you remember, there is Deepa Rani Israni from Siddi MP. She has written management of previous LACS with post-dated with adherent uterus with placenta accreta. And sir must be remembering Deepa Rani Israni, I think.
Yes, sir.
Yes.
Okay.
So, Dr. Pikesha, sir, so can you just answer the question? She's asked regarding the previous LACS with adherent placenta accreta. So it's a wide question actually, not very specific, but you can give some practical tips to her.
Nightmare to have.
Yes, and she is remembering, sir, because
Yeah,
she's
but
a student.
yeah. But what she wants me to tell her, it's a big topic.
I know I got it, sir, but I just read a familiar name, and she was my registrar when I was working with you.
Okay, it's very simple. As we are not running late for a change in a webinar, we still have 40 plus minutes for Dr. Sylvia from Italy to talk on latest things about folic acid and tetrahydrofolate. But when you talk about placenta, which is morbidly adherent, remember one thing, majority of them don't come with bleeding. If it is really morbidly adherent placenta, they don't have bleeding. So what you have to remember, whenever a patient of previous LACS comes, irrespective of your complaints, you must get an ultrasound done, either yourself or from a good sonologist. See that the placenta is not covering the lower segment, the previous scar side. If so, see that it is not morbidly adherent placenta. Remember this. If the placenta is on the posterior wall, you don't have to bother about morbidly adherent placenta in a case of previous C-section. But if it is on the anterior wall, reaching the lower segment, what is required is you need a good ultrasonography, 3D power Doppler. If you have 2D ultrasound plus 3D power Doppler, there is no need of MRI. MRI is needed only in two conditions in morbidly adherent placenta. Number one, when you have a placenta which is invading probably bladder and you are not sure, you want to make 100% sure that yes, it is invading the bladder wall, then you may ask for MRI. Or else, when the placenta is covering posteriorly and coming anteriorly, that is a situation where you may ask for MRI for its adherence. Otherwise, like what we used to do, we have published this series of 31 cases of morbidly adherent placenta, all managed conservatively. We used to have the patient for elective C-section, send them to interventional radiology department, put a catheter in both the uterine arteries, bring them to operation theater, do a classical C-section or transpondal incision, get the baby out, put a tie a knot on the cord next to the placenta, close the uterus and come out. And then we used to give one shot of methotrexate after 4 days of C-section, 3 to 4 days of C-section, just one shot, 1 milligram per kg body weight. And we used to do every third or fourth day beta HCG and ultrasonography for placental volume. And we have managed all these cases. We had one death, which was because the nursing staff gave the next day methotrexate, same dose again. She went into toxicity, landed up in ICU, but we could not save her. Otherwise, all rest of the patients went home. It takes long time for you to follow up these patients. Please remember, you must have patience and your patient must be intelligent enough to follow your instructions and come for ultrasound and beta HCG repeatedly. It's a big series that has been published in Journal of Foxy.
Thank you, sir. You have summed up the most difficult part so easily. And there are so many congratulatory messages. One from Asha Advani from Mumbai, and she's congratulated to all the speakers, Dr. Sanjay Gupta,
Very
Dr.
good friend.
Mukesh Jha, and Dr. JB Sharma. Very informative and summarized so well. And it will help in bringing down the maternal and neonatal morbidity and mortality. It's her views. And we have one question before we move on to the Dr. Sylvia's talk. It is related to folic acid for Dr. JB Sharma. Dr.
Yes, ma'am.
Ravindra Kare from Tasagaon has asked, sir, what do you recommend? Folic acid uh, only till completion of the first trimester or for the full term pregnancy? For the entire term, 9 months of pregnancy. That is the
Okay. No, man, I prescribe in periconceptual period and first trimester. Later on, I prescribe them iron plus folic acid. So, but if they have deficiency of the folic acid, like if proven like patient has got megaloblastic anemia, then I continue them folic acid throughout pregnancy, 5 milligram. But otherwise, otherwise, I mean, the traditional iron preparation usually have 500 microgram of folic acid in them, so that is good enough. Yeah, but definitely
So
now I think maybe we may change the practice now with this new folic acid is available, so it may be desirable to give this, I mean, throughout pregnancy, especially those patients who have deficiency of the enzyme.
Okay, thank you very much, sir.
Thank you.
We can move on now, Dr. Mandani.
Oh yes, we can move on. Our next speaker is Sylvia. She is the scientific marketing and senior marketing manager of the Gnosis Bio Research and from Italy. We all of us know that the situation in Italy is settled down as far as COVID is concerned. Hope to hear from her regarding the folic acid and its recent advance. What are the preparation and all. So I welcome Miss Sylvia to present her talk.
I will share my screen right now. Good afternoon or good evening to everybody. You see the screen?
Yes.
Yes.
Okay, let me check if it works. Now it works.
Yes, it's fine.
Yeah.
Dr. Pisoni, we can see the next slide as well.
Yes.
You can stop that.
Okay.
Cross is on the top.
No, it's not that. Just one second.
No, if you go to the screen, full screen, then probably it will go. Yeah.
So, Ms. Pisoni, I think you need to double show.
Okay.
Yeah.
It's okay.
Yeah, that's fine.
We can see your slide. We can see. We can hear you. So carry on.
Okay, thank you very much. So nice to meet you. I'm Silvia Pisoni from Italy. Now it's around 3 p.m. here. It's very cold with sun. So I just want to highlight that we are going to talk more from a pharmacological point of view, because I'm not, I'm a doctor, but I am specializing in pharmacological chemistry. So I will just give to you a short overview about the different kind of folate. As already explained, folate plays a very important role in all the different kind of cell division, in DNA synthesis, and in all the process involved in human growth and development. Human need to maintain a right dietary intake of folate during the different kind of stage of their life. And the first important thing to highlight that human cannot synthesize folate, and women that do not consume adequate quantity with their diet require supplementation of folate to prevent some problem like neuronal tube defect, and this is absolutely established by several health authorities worldwide, like EFSA in Europe or FDA in US. The main problem of folate in food is that folate in food are really unstable and are really susceptible to oxidation. So during all the processing of food, manufacturing and storage, we really lose a big amount of folate. We are able to absorb the 25-50% of the folate depending from the different kind of food. At room temperature storage, we lose up to 70% of the folate activity in 3 days, and all the cooking process in water can increase the loss to 95%. That means that even if there are a lot of green food rich in folate with the use in the normal food process, you really lose the big part of active folate. So the folate deficiency reasons are a lot. First of all, the low intake in healthy people, and the inability to cover the right need with the normal diet. The increase of need, like in pregnancy, that is not matched by an increase in intake. Some enzyme defect involved in metabolization, and wait a moment.
Hello.
Hello, no, I'm here. I tried. I don't know why there is a lot of noise, and malabsorption due to the different some kind of disease, and also the use of folate could be reduced by some drug use. When we talk about folate, often we talk about folate from food. So there are some structurally related compound from food. They are naturally found in food, but they must be hydrolyzed to be absorbed, and they are, as I explained before, really unstable. Then we have folic acid. Folic acid is a synthetic oxidized form of folate. It was synthesized the first time in 1945. It's more stable than the natural form, but is not active as it. So folic acid needs to be metabolized through a biological process to be activated in his active form, that is the methyl tetrahydrofolate. And he is added in supplement, and in some country, like for example US, it was also added in some food like flour, white flour, bread, and so on. The folic acid that is found most commonly in vitamin supplement is not active folate. What does it mean? It means that folic acid needs to be transformed into a first step through absorption, that is dehydrofolate. Then he must be transformed in tetrahydrofolate, and then in 5-tel-methylene tetrahydrofolate, and with the last step, with the methyl tetrahydrofolate reductase, it will be transformed into the active form, the methyl folate active form. So the most important thing is that we have two steps that are very important. First of all, the ability of our intestine to absorb folate, and this is absolutely a limited ability, and so a lot of folic acid is not well absorbed and remain in blood as unmetabolized folic acid. And then the ability of the people to transform it efficiently from acid folic to 5-methyl tetrahydrofolate. When we talk about methyl tetrahydrofolate glucosamine salt, like quadrifolic, we know that quadrifolic is the active form of folate. So it doesn't need any kind of metabolization, is already usable from the body with no transformation at all in body and tissue. It's very important because the 5-methyl tetrahydrofolate is the only biological form of folate. If we analyze the concentration of 5-methyl tetrahydrofolate in cord serum in mother and also in the newborn, we saw that approximately there are 2 times higher concentration of 5-methyl tetrahydrofolate, and 5-methyl tetrahydrofolate is the main form of folate you can find in serum of mother. It's double in serum of neonates. And we can say that the 5-methyl tetrahydrofolate is the main folate form in cord blood. More or less in the mother, the 82%, more the 89% of the total folate we can find in the blood of the newborn. So in this graph, you can see the concentration and percentage of the different form of folate in maternal serum and umbilical cord serum from mother and newborn, just to highlight why it's really important that folic acid is efficiently transformed into reduced folate. The biotransformation of folic acid into the 5-methyl folate is critically regulated by 2 polymorphic enzymes. The first one is the hydrofolate reductase, that is sometimes not so efficient, and it's a polymorphic enzyme, so it could be less efficient in transform folic acid into the hydrofolate. But the most important is the methyl tetrahydrofolate reductase. This is a rate-limiting enzyme. That means that this is the enzyme that organizes the how quick the transformation of folic acid works. More or less 10% of the world population is affected by homozygous TT MTHFR polymorphism. In some ethnic group like India, for example, Italy is one of the countries where the incidence of methyl tetrahydrofolate polymorphism is very high, is around 26%. The country where the incidence of this polymorphism is higher is in Mexican people, where it's around 32%. There are already explained 9 common variants of mutation in methyl tetrahydrofolate reductase, already described it. The 2 most common reported are the C677T, that is the most common, with a homozygous variant of this enzyme mutation. You will keep only the 25% of the enzyme activity. Often the people with one kind of polymorphism in one gene is also responsible of another polymorphism in the other. That means that more or less also the heterozygous variant could have a reduction of ability to convert folic acid into active folate around 50%. That means that even if you give the right supplementation with folic acid, we will not reach the right level of active folate into blood. Studies have found that about 60% of people are heterozygous for a genetic mutation in the production of the enzyme methyl tetrahydrofolate reductase. These people are more or less called as intermediate metabolizers. That means that more or less they are able to transform the 50% of folic acid in usable folate. But there are around 10 to 25% of people that are able only to transform a very small amount or none of folic acid into an active folate. There are a lot of clinical publication and epidemiological publication about the incidence of polymorphism, because the recent studies show how low level of folate are linked with problems related with pregnancy, first of all, not only related to a right pregnancy, but also related to other problem linked with a good pregnancy, but also some other problem like cardiovascular disease and incidence of depression. So that there are a lot of new publications that show how is often present the 5-methyl tetrahydrofolate polymorphism, with an incidence that could be evaluated around 20%. Some data show a prevalence in South India polymorphism around 9-10%. More or less in some country, like is explained, China, Italia, also China, India, and a big part of Latin America, the incidence is more or less around 20%. The big problem of 5-methyl tetrahydrofolate polymorphism is not only that you will not able to reach the right quantity of folate in blood, but the other linked problem is that you will increase the quantity of unmetabolized folic acid in the body. Since the implementation of folic acid fortification and also the increase of use of nutritional supplement with folic acid, it's quite common that the quantity of folic acid that could be not transformed into the active folate remain in blood. And there are a lot of clinical studies that show that high level of unmetabolized folic acid are linked with some problem. The reason why we can find unmetabolized folic acid content in blood are related to the enzymatic saturation of the hydrofolate reductase, the polymorphism associated with methyl tetrahydrofolate reductase enzyme, but also the not controlled assumption through nutritional supplement and fortified foods. The potential toxic effect of metabolized folic acid are linked to a decrease of the immunitary system efficiency and a reduction of natural killer cytotoxicity, and also the risk of decrease the activity of immune system to kill off the malignant or pre-malignant cell. While the scientific community is evaluating the risk and the possible concern of unmetabolized folic acid on public health, according to the food fortification, several publications recommend to replace folic acid with 5-methyl tetrahydrofolate. This because with the 5-methyl tetrahydrofolate glucosamine salt, you will first of all reach the right amount of active folate in the body that is absolutely necessary for a good pregnancy, but also for other medical concerns, but also you avoid the risk to potential accumulation of unmetabolized folic acid in blood. Just to give a picture of the situation, right now we have around 100 publications every year dedicated to the risk of 5-methyl tetrahydrofolate reductase polymorphism, because the scientific community know that low level of folate are really linked with a lot of different medical issues, and so they try to evaluate how the polymorphism is well known in the different countries. The most common use of folate in pregnancy are, first of all, to protect from some birth defect, but also for fertility and reproduction. There are some clinical evaluations that show the efficacy of high level of folate in male and female infertility. The high level of homocysteine that is quite common in recurrent pregnancy loss, preeclampsia, and also to actively protect from baby blues, so from the mood in pregnancy and postpartum. The methylation of DNA and fertility are linked with different kinds of the step important for a good fertility, and also all these problems are related with the right level of homocysteine. We talk first a little bit about one-carbon metabolism. Folate and methyl tetrahydrofolate play an important role in all the process related to one-carbon metabolism. That is a key biological synthesis for DNA and to provide methyl group to ensure the chromosome stability. Folate deficiency is related to different kind of problem. The right folate can increase the one-carbon metabolism efficacy, and that means that will decrease the level of homocysteine and will help a healthy pregnancy. We have a lot of clinical validation about the use of active folate in prevention neuronal tube defect, in spontaneous abortion, and also in lactation. And a lot of clinical validation about the efficacy of active folate in hyperhomocysteinemia, that is often an independent causal factor for pregnancy complication. We know that women with hyperhomocysteinemia have increased risk of bad pregnancy and also higher risk of preeclampsia. We also evaluate, for example, the link between right level of folate and fertility problem. So it's well known that often women and men with methyl tetrahydrofolate reductase polymorphism have a higher risk of fertility problem. In this clinical study, we evaluate a population with a high percentage of heterozygous and homozygous methyl tetrahydrofolate polymorphism. There were 33 couples with at least one partner with methyl tetrahydrofolate polymorphism. Most of these women was previously treated unsuccessfully with high dose of folic acid, around 5 milligrams. That is commonly a high dose of folic acid. And all had repeat fetal loss or premature loss. After a treatment with active folate, there was 13 spontaneous pregnancy and 13 pregnancy after assisted reproduction, and an increase of ongoing pregnancy rate around 86.7%. So what is the importance of 5-methyl tetrahydrofolate? First of all, it is immediately and completely bioavailable. All the natural folate are turned into disactive form. So any kind of different folate you can take, like folic acid, will be transformed in 5-methyl tetrahydrofolate, so into the active form. The 5-methyl tetrahydrofolate is the only one that is able to cross the blood-brain barrier. This is really important for all the problems related with low level of folate and mood impairment. It does not mask the vitamin B12 deficiency, and is the essential form in which folate are stored into the human body. So if we have to make in comparison folic acid and quadrifolic, we will have, first of all, a high bioavailability, absolutely no risk of unmetabolized folic acid in blood with a low risk of toxicity. There is no requirement of metabolism. There is no requirement of all the enzyme, dihydrofolate reductase and methyl tetrahydrofolate reductase efficiency, no masking effect of vitamin B12, and also no risk of high level of unmetabolized folic acid with some chronic disease. We make some comparison in terms of bioavailability of methyl tetrahydrofolate if compare at the same dosage with folic acid, and we have an increase of the efficacy of plasma folate more than what we can have with an equimolar dosage of folic acid, 400 microgram compared with 460 microgram of 5-methyl tetrahydrofolate. We also compare the difference of bioavailability of quadrifolic with the other methyl tetrahydrofolate calcium salt, and we see that the glucosamine salt is the more bioavailable in two models. One model in rat, like we can see in this kind of graph, 20% higher, but also in human model where we can see that the 5-methyl tetrahydrofolate hematic peak produced by an equivalent dose of the two different folate source show a better bioavailability of the glucosamine salt if compared with the calcium salt. The big difference between glucosamine salt and calcium salt is linked to its solubility, and an increase of solubility increase the effectiveness and safety of the glucosamine salt, so of quadrifolic, if compared with the calcium salt. High water solubility means that the product may be better absorbed by mucosal cells, and that may facilitate access to the blood and circulation with the improved of the bioavailability. The solubility of quadrifolic in water, and this is declared from AMC, so it's documented by the higher organ in Europe, is 100 times higher than the calcium salt. So the product is better absorbed than the calcium salt. Also, the status of quadrifolic is an amorphous status that increase also stability and helps all the process of absorption of the product. We don't need to use any kind of agents, synthetic agent, to increase the solubility of the product, and the product is absolutely natural and vegetarian. So glucosamine, the salt of quadrifolic, is a natural compound found in almost all the human tissue. The last slide I would like, one of the last slides I would like to highlight is this one that is related to the mechanism of action. So how and why quadrifolic is able to reduce the level of homocysteine in blood. This is because quadrifolic plus B12 are able to transform homocysteine in methionine, so the right level of quadrifolic and active folate in blood decrease the level of homocysteine more efficiently than folic acid, because folic acid is not the active form. This is a clinical study when we investigate the efficacy of two different nutraceutica, one containing 400 microgram of 5-methyl tetrahydrofolate, the other one containing 5 milligram of folic acid. At the end, we reach and we stabilize the level of homocysteine in more than the 55% of the patient, just treated them with the right amount of active folate. Glucosamine is a natural occurring endogenously produced molecular, is more or less common in all the normal tissue. The intake of glucosamine from quadrifolic it's more or less 2,700 times lower than the accepted dietary dosage. Quadrifolic is approved worldwide for pregnancy and lactation, but also in US is approved from FDA for as a medical treatment for mood and depression, is approved from and is a novel food in Europe, and it has the GRAS status that the generally recognized as safe that was hallowed in 2020 in US. The notification and was hallowed in 2011 from FDA in US, and so it can be included in food supplement and also in medical food with high level and high dosage, 10 times more high than the normal nutritional supplement. It's also GRAS for USA, and it's also approved from 2013 from EFSA, like a good option to substitute and a good source of folate for all the nutritional supplement and food supplement. Also, after this, he obtained in 2050 the TGA approval from Australian government, and in the same period, the approval from the Health Canada authorization. So right now, we obtain also the approval in all Latin America and in the use of pregnancy in Brazil from Anvisa, and also as in medical food for different kind of use in Latin America. There are hundreds of supplements commercialized in the world with several health applications. The most common, of course, is related to pregnancy, more or less. All the countries in Europe at least have 5-6 products that change the normal folic acid or the calcium salt with the 4th generation folate quadrifolic. In Italy, Germany, Switzerland, France, so more or less in all the European countries, but also it's the first choose folate in US market, where it's defined as the fully active best folate we can find because it's the most innovative. There are a lot of products also dedicated to infertility in Europe and also in US. I just put some example just to show that really there are a lot of pharma companies that have products like this. The quadrifolic as 4th generation folate is patented. So we have 2 patents, one in US, one in Europe, about the composition and also about the kind of salt that is exclusively and is just produced from us. All the authorization from the different kind of FDA, EFSA, and also the trademark that is registered worldwide in all the world countries as a protected brand. So I have finished. Thank you. I will stop to.
Oh, great. Thank you so much for enlightening us about 4th generation folic acid. Frankly speaking, many of us are less aware about this 4th generation and explaining how really it works, including those who have got a MTHFR C2T677 polymorphism. That's something regarding polymorphism. So thank you so much. Dr. Komal, you can take over.
Yes.
Yeah.
It was an excellent talk by Dr. Pisoni, you explained so well, touching all aspects of the folic acid. And there are a lot of questions, but I would like to take some comments from Dr. P.K. Shah before we begin with the questions. Dr. Sir, would you like to make some comments?
First of all, I must congratulate Sylvia.
Thank you.
For an excellent talk and giving us in-depth information about the latest form of folic acid. In India, we are used to prescribe folic acid as such. And I'm sure with the availability of new product, we will change to new product soon. You have given us in-depth information about the advantages. That is very important because this is what is required for gynecologists here in India. Whenever a new molecule comes, it's not a new molecule, it's a different form of the same molecule.
Yeah, you are right.
We must know exactly and clearly that in what way it is superior to the existing molecule that we have been using. And you have done a fantastic job. And I thank Anchor people for having this talk in this particular webinar. And I'm sure a time will come when before you give us next lecture, sometime in future, we will tell you that good number of us have been using the new product. Thank you very much.
Thank you,
Komal,
Doctor.
I must thank you for having 4 different, totally unconnected talks, literally, let me tell you, in this webinar. And I'm very happy that you have good number of obstetricians and gynecologists from Foxy who are attending this. More than 2,000? How many?
More than 2,200.
Wow, that's a great.
Wow, it's great. Many compliments to all the organization. You were great.
Thank you. Thank you.
No, sir. It is all 4 talks were connected.
Yeah,
See,
they were connected.
Talks about
In a way, yes.
polymorphism.
In a way, yes.
If we think about gynecologists thinking about polymorphism, if I will explain only one, then that will be MTHFR C2T 677. So polymorphism. Then we went on to high risk pregnancy. Then we went on to the different forms of folic acid, and finally the summary of it. So it's connected for me.
Okay.
Okay.
So there are some few questions for you, Sylvia. And we have Dr. Kiran Rao from Gonda asking, what is the dose of folic acid that we should give to homozygous MTHFR mutation females? So exactly the dose is, I think, she wants
the dose allowed here in Europe is 400 microgram of folic acid. That is also the dose of folate. Just to be clear, when they write in the final packaging, they indicate the quantity of active folate that at the end is 400 microgram. That is not related to the quantity of the salt, but it's just the quantity of methyl tetrahydrofolate. For folic acid, the main problem that is we don't know how much folic acid is transformed into the active folate. So this is the main question. When I explain that it's really a topic that is interesting worldwide, is because right now is well known that there is a high incidence of people that is not able to transform efficiently folic acid into the active form. So even if you give high quantity of folic acid, they are not able, they have an ability to transform 25-30% of folic acid into the active folate, so you don't find in the blood the right amount of active folate. So the quantity is 400 microgram, but it depends of how much you are able to transform it. And just to be clear, here often when you have problem in frequency loss of infertility, a lot of people here test the polymorphism with a genetic test to understand if the problem is related to the low level of folate. Of course, with an active folate, you will have for sure the right quantity of folate in blood because you don't need any kind of metabolization.
Thank you so much.
Yes,
Dr.
sir.
K.B. Sharma,
Sir has got
Dr. P.K. Shah wants to make a
This question is for both Dr. J.B. Sharma as well as Dr. Pisoni. Have you heard of folic acid toxicity? Have you ever No, I'll tell you why. The dose that we are supposed to give during pregnancy is around 500 microgram, and otherwise it is around 400 microgram. And we give 5 milligram twice a day, literally.
Once a day.
So have you heard of folic acid toxicity? Is there any entity like that?
No.
Yeah.
Anyone can answer.
Yeah, the toxicity of folic acid is most common, to be honest, in the country where there is fortifying of food with folic acid, because people take supplement plus take food, and they are not able to transform folic acid, but the elimination of folic acid is not so fast, so they find a high percentage. Also, with the normal supplementation, if you take it every day, you can have some unmetabolized folic acid in blood that could be linked with some health problem. Also, this is a new thing that is evaluating, but just if you go to PubMed and you digit unmetabolized folic acid, we will find around 50 new publication only in 2020 on this topic, because they understand that probably folic acid is not the right solution, because if you are not able to understand if people is able to transform it in the active form. So this is more or less, but this is really a recent evaluation, so number changing a lot. And just to highlight, there are also a clinical study that link 5-methyl tetrahydrofolate polymorphism, so the inability to transform folic acid in active folate, with a lot of different kind of medical health related problem. Of course, the most important one is the one related with pregnancy, because as you explained perfectly before, the low level of folate are linked with big problem in during all the pregnancy of the women. And for sure, it's also here in Italy, it's mandatory to start. And just to explain, there are some study that is evaluating to put into the pill, preconceptive pill, the active folate, because they know that it's important to start a supplementation of reduced folate as soon as possible during a pregnancy.
Thank you so much. Komal, go ahead.
Yes, and now Dr. J.B. Sharma, as you said initially that you would like to give the combination of folic acid till the term. So there is a question that which is the best folic acid combination to take, and also a part of this question that are there any recommendations for use of vitamin D3 with folic acid in the first trimester?
Not, we avoid usually vitamin D in the first trimester, but like only folic acid is given in the first trimester. But definitely there is no contraindication of giving vitamin D. If there is deficiency, proven deficiency, then only give. Generally, like I tend to give them after 12 weeks of pregnancy, vitamin D, 60,000 units weekly if there is proven deficiency is there. And as far as like iron and folic acid, like even the simple preparation available from Government of India, Ministry of Health, the Folifer tablet. So they do contain 100 milligram elemental iron and 500 milligram of folic acid. So which can be, because after 12, till 12 to 14 weeks of pregnancy, we have to give proper folic acid depending upon the patient. Like if she is low risk, then we can give her just 500 microgram. If she is high risk, then we can give her say up to 5 milligram, as Professor P.K. Sir just said. And after 12 to 14 weeks, unless they have got megaloblastic anemia or proven deficiency of folate, then we tend to give them just like any iron preparation, even ferrous ascorbate. Usually, most of them do have 500 microgram folic acid in them. So if there is no megaloblastic anemia, there is no proven folate deficiency. So that is enough. So you can stop giving them folic acid. But if there is proven folate deficiency, or you are giving her some other medication, like patient is on anticonvulsant drugs, or other anti-folate drugs, then you have to give 5 milligram pharmacological dose to them, or now this quarter folic acid has given, so that can be given. Yes,
Thank you, Dr. J.B. Sharma. Ms. Sylvia, now we know that we are here in India and we have been using the folic acid, all the generations, and now you have talked about quadrofolate. So do we now prescribe quadrofolate to all our patients or to certain group of patients? What do you recommend?
Okay, the point is that it's not easy to make a recommendation because for sure we are not able to know in advance if people will be able to use folic acid to transform in the active folate. So reduced folate is, but it's my opinion, the best option because you are sure that you cover the 100% of your patients. So at the end, we will not have the problem to understand and to analyze if it is possible or not. So the recommendation is that if it's possible to offer the active form of folate as fourth option, so you will not have any kind of problem related to the ability or the incidence of methyl tetrahydrofolate reductase with polymorphism. That is in India is quite high. So India is one of the countries with a higher incidence with Spain, Italy, and France in Europe, and two free countries in Latin America. Here in Italy, that's why we are really strong in this field. It's very, very high. In South Italy, we can reach the 35% of people. That means that 35% of women are not able to use folic acid. And this is a big problem. So honestly, the 80% of the product in the market for pregnancy here in Italy use reduced folate and stop to use folic acid.
Thank you so much. And Dr. Mandakini, you want to make a comment?
Yes. We also studied, and one of our paper on MTHFR polymorphism has been quoted in Williams' textbook of obstetrics. That was long back, and the population that we see is 10% of the population carrying heterozygous for C2T 677T polymorphism. And then quite rightly said that it has to be fourth generation so that we bypass that. What happens is if somebody is carrying that polymorphism, this enzyme becomes thermolabile. What is thermolabile is? The enzymes becomes dysfunctional at body temperature. So this enzyme doesn't work, and hence the folic acid is not usable. And if we are not doing this polymorphism test, then it is better that I fully agree that we should bypass that step and then directly prescribe this medication. And probably next year or so, we all of us must be changing our practice. And thank you for enlightening us. Dr. Komal, you can conclude the session.
Yes. And before we conclude, everyone, you can download the ICOG certificates. We have been granted ICOG 1 point, and it is all available on the same link. Session will show you how to download it.
Yeah, great.
May I request everyone to just click here to get their certificates.
Okay, great.
And also this quarter folic is available as mom B9 in India, is it?
Oh,
Mom
great.
B9.
Okay.
Yes, sir. Yes, sir.
Nice.
Mom,
Yes, sir.
What is the cost of it? Cost?
So it's a strip of 10 capsules, sir. So it is 172 rupees per capsule, 10 capsules.
Okay.
One OD.
One certain.
Yes.
Yes.
One step.
Sir, it's
Thank you
really
so much.
brilliant to see Professor P.K. Sir. Good
Sir,
evening.
same
How are you,
here.
sir?
Happy New Year, Dr. J.B. Sharma, sir.
Sir. Haan, sir.
Yeah.
Ciao, ciao.
I've been
Thank you.
affiliated with sir so long. Yeah,
Bye, Sylvia. Thank you very much for joining.
May I request Dr. Komal to
We
kindly...
formally thank the esteemed speakers for today, Dr. P.K. Shah, sir, for accepting the invitation graciously, waiting till the end, answering all the queries and giving expert comments. Dr. Sanjay Gupte, sir, it was really a pleasure to hear his talk on genetic polymorphism. Dr. J.B. Sharma, in spite of his busy schedule and he being stuck in emergency, he has joined and shared the knowledge about different type of folic filtration. And Sylvia, you have been so kind enough to be from the beginning and giving us this newer knowledge about this new molecule of quadrifolate. And Dr. Mandakini, the genetic and people, she has been really an asset. And so well, we have now conducted this webinar, a Foxy webinar, and all audience. There are so many congratulatory and pleasing messages. I think everybody, all the faculty has read all over, not only from the particular part, but all over India. and it has a tremendous response we have got to this webinar. I thank Science Integra TOG team and this platform for bringing us all together, and MCure team for this wonderful opportunity for us to discuss, share knowledge and learn more. Thank you all, and we'll see in future. Thanks. Thank you so
Thank you,
much.
everyone. Thank you very much. Good night.
Congratulations, Dr. Komal, for organizing so
Yes,
well. You
very
are
good.
wonderful.
Thank you so much.
Yeah.
Thank you.
You are